Good afternoon, everybody. I like to walk around, so I'm going to move around a little bit. Jerry and I are going to share this presentation, and first let me start by saying is that I'm the past chair of the Board of Licensing for Drug Abuse Professionals in New Hampshire. It's kind of my role right now. I'm the past of just about everything. So I'd like to begin by welcoming you, and how many of you are currently using pharmacotherapies in your practice? Okay. How many are currently using motivational interviewing in your practice? Great. So for a lot of you, this is going to be a review, and for some of you, this is going to be new information. We'd like to begin by just talking about how people change, and that people are ready, willing, and able to change. Typically, people are willing to change when they have a lot of internal motivation to change. And we know that there are external forces that can help with internal motivation, but we also know that everybody changes in their own pace, and everybody has a goal. So for some people, the goal for change may be to keep their job. For other people, the goal for change may be to stay out of jail. For other people, the goal for change may be to appease their family. And for some people, the goal for change is, I'm sick and tired of being sick and tired, and that's the motivation for change. We have to understand with motivational interviewing that motivation is something as counselors we need to learn how to elicit. And that's a skill that we get by practicing motivational interviewing. And it's also a skill that we have to learn to develop, because most of us really aren't taught this. We also have to understand that motivation is like our blood pressure, that motivation varies from day to day. When you think about your blood pressure, you think about motivation to change, you may get up in the morning thinking, I'm going to run 5 miles today, I'm going to eat healthfully, and you get up and it's pouring rain, and you've got a very stressful day at work, so instead of going out to run, you order pizza and you sit in front of the television. So I think that it's important to understand with our clients is that motivation is high, low, or it's just there, and it's our job to learn how to elicit motivation. So when we think about being ready, there has to be a recognition on the part of the individual that there's a need to make a desired behavior change, and that they're mentally prepared to attempt that behavior change. And it's really important for us never to underestimate how the energy, the effort, and the time it costs for people to change. If any of you have ever tried to lose weight, stop smoking, stop using alcohol or other types of substances, or ever really tried to commit to a wellness plan, you know that it's not something that's easy to do. We also have to be willing, and there has to be a really strong desire. We often hear, to what length are you willing to go to change? How important it is for you to change, and how confident is it that you can change? And then how able is somebody to be able to really to change. Today, Dr. Covington talked about, people who are incarcerated and really want to change, and they come out and they have no housing, they don't have shelter, but they're expected to stay abstinent. So while they may be very willing, how able are they to change? And I'd like to turn this over to Jerry.
Again, talking about the stages of change, a lot of you are familiar with that. And I know it says 5 critical steps, when in reality the 6th step is retrying or relapse, but we'll get to that. And what's most important in this is, as clinicians, recognizing with our clients, what stage of change they're in. That way, when we're trying to do interventions with them, we're working with them where they're at and not where perceptually we think they might be. So looking through those stages. And again, and Mary may have already said this, and if she didn't, I'll restate it, and there's a lot of slides. We're going to go through some of them. We're not going to go through all of them. They may be up there. They may go by quickly. So don't think you're getting cheated because you have all the information anyway. Okay? Well, pre-contemplation, a lot of our clients come into the office in this stage, and that's where they're either unaware or underaware of what the issue is. Something has brought them there. They may not be there by choice oftentimes. Contemplation, this is where a lot of the clients end up maybe after the first 2, 3, sessions, or it could be 2 or 3 months. It's where they're aware of their problems, but they're still ambivalent, and that's where you're trying to tip the decisional scale with them at this point, is to get them to begin looking at what those issues are. The preparation stage is clients begin making a commitment to action, to change, and to develop and begin looking at developing a plan. These are the clients that we oftentimes find fun to work with because they're beginning to look at doing some work with us. The action clients are the ones that we look at on our schedule day in and day out. Those are the ones that are respite for us in the middle of a busy day. These are the clients that are coming in that are wanting to work. They've got a plan together. They recognize what it is they need to do. They're working in concert with you. And remembering, all of these stages don't necessarily fall in order. Folks move around. They might be in an action stage and then move back to contemplation because of some of the issues that are coming up. So don't look at these as starting in the beginning and working straight through. The maintenance stage, this is where, the client's been coming in for a while. They may have relapsed. They may have gone back to trying using. They may have gone back into former behaviors. But then they come back and they continue maintaining. They continue to work on what it is. The last stage is the retry, or the relapse, and this is where they slip back into old behaviors. And that behavior may not necessarily be return to use, whether it's alcohol or drugs, but it's a return to former behaviors. And again, if you look at the handout that's in there that shows the stages of change, it's not linear, it's circular in terms of how folks enter it and exit it. And generally, we don't see relapse happening until after the contemplation stage, or after the preparation stage, because they have to begin making some change before they can move backwards or move back into former behaviors. What's most important about all of this is that as clinicians, we recognize where our clients are at in that change model, because we can't work with them, we can't begin looking at behavior changes if we don't know where folks are at.
When we talk about motivational interviewing and we talk about motivational challenges to changing, those of you who use motivational interviewing know that what happens in a counseling session has more to do with what we, the therapist and clinicians, are doing rather than the client. And that motivational interviewing is a style of counseling. It's something to have in your toolbox. Motivational interventions are one of the clinical interventions we have that are very effective. They're evidence-based, but it's one of many things that are in our toolbox. And what's really important to understand is that we are looking at change to see how it's to kind of really see how we as counselors affect what happens with our participants. And we have some video clips that we're going to be using during the presentation to kind of highlight some of the things we're talking about. Motivational interviewing, there's a style and spirit to it. It's really important when we think about motivational interviewing. We're really trying to make the client work harder than we are. When we're doing motivational interviewing well, the client's doing all the work and we're sitting back and thinking, wow, this is really cool. And it's important to understand that with motivational interviewing that we're really trying to elicit change within the individual. So that's what is the hallmark for motivational interviewing. Motivational interviewing is predicated on collaboration, being able to evoke motivation and a decision to change from folks, and autonomy. Collaboration, which means that we're working together. It's not me as an expert telling you what to do. And that's really one of the hallmarks of motivational interviewing, is that this is not an expert-driven type of intervention. It's a collaboration between two people. And then we're trying to get an evocation, to call something out from within. What is it that's really important to that client that makes them want to stop using alcohol or stop using alcohol and drugs? What is their goal? What is the thing that really makes them want to say, wow, you know, I would really rather go to college than sleep at the shelter? And then the autonomy. the right or the power to govern oneself. And that's another thing about motivational interviewing that's a little bit different than addiction counseling. Having autonomy, being able for the client to make decisions. We're going to talk a little bit about menu of options. It's really important for the client to develop the plan that they want, not what we want for them. And most often, the plan that's the most successful is the plan that they create. So how does a counselor evoke a client's internal motivation to change? By focusing on the client's perspective. What is their perspective? I had a woman that I used to work with who, she had an honorable discharge as a sergeant from the Air Force. She was very successful over in Germany. She came home to New Hampshire and her marriage fell apart. She started drinking and using cocaine. She ended up as a prostitute on the streets of Manchester. And when we started working with her, she was coming out of prison. And when she came out of prison, we all saw this woman who had tremendous strengths, who had a very successful life prior to her addiction, and we had a lot of hope and expectations for her. She came into a residential program for people with dual disorders, and she stayed sober for a little while. She got involved in self-help. She reconnected with some of her old friends and her family, and she went out and she relapsed. And we said, well, what's going on? And she said, you know, this recovery thing isn't all that I thought it was going to be. When I was on the street, everybody came to me. I was the queen. And now that I'm in recovery, I'm the one who got left behind. I'm the one who has nothing. So our perspective was much different than hers. What are the reasons for change? You know, being able to ask somebody, what's important to you? What would, you know, is going out and scoring dope more important than having dinner with your family? What's the most important thing for you? And then what are the barriers to change? Housing, transportation, funding. A lot of people want to change, but they're not able to. And then previous attempts to change. Learning what worked well when they attempted to change in the past and what didn't work well. So we're going to talk about different strategies. We're going to talk about reflective listening, eliciting change talk, and rolling with resistance. We're going to talk about different types of behaviors and abilities that people have that as clinicians that we can use to help folks enhance their motivation to change.
Okay, well, I believe one of the favorite parts of looking at integrating stages of change and motivational interviewing is looking at the whole prospect that we have before us now, being able to integrate pharmacotherapy as part of that. And one of the things we want to talk about over the next probably 45 minutes is, you know, how we're going to do this with motivational interviewing, how we're going to integrate pharmacotherapies, and how that understanding is extremely important in terms of working with our clients so that they understand. Because I think most of us know our clients are much better educated today than they were 10, 15, 20 years ago. The internet, just their access to information in primary care physician offices, and what they learn from each other. So we have to stay at least a chapter or two ahead of them, and that's real important. So what we're going to do is look at what some of those pharmacotherapies are. I don't know about you, but I've been around since 1972 doing this, and in 1972, when Bruce was still in grade school, there wasn't a lot in terms of what was available in terms of intervention strategies beyond counseling and anonymous fellowships. And what's happened over the past 40-some years is amazing, and then pharmacotherapy is certainly one of that. But what we got to be real careful of is we're always being introduced to what's the next best great thing, or what's the magic bullet, what's the quick fix. Not only as clinicians are we sometimes looking at what the quick fix is, but we know a lot of the clients and the family members that come into us are looking at what can you do. I'm bringing them to you. What can you do to fix them? So what we don't want to do is confuse any of the styles or strategies or pharmacotherapies as being that fix. First of all, the client has to be willing to engage in it, and there's components to that. what we're going to do is talk about what some of those are. What's real important as clinicians, unless we're a prescriber, and I don't know how many in here are prescribers, the information that we're going to present to you is for informational purposes. As a clinician, if it's outside your scope of practice, you're not to be making recommendations as to, whether they should or shouldn't be involved in pharmacotherapy intervention. But as a clinician and somebody that's with clients on a more regular basis than oftentimes the psychiatrist or the physician, you're in a better position to know oftentimes what the needs of those individuals are, and to help a client make and arrive at whether or not having medication intervention is a strategy that can be effective for them. But what's most important is that you redirect them if they end up on a medication. If they're having problems with it, side effects, whatever, or it's not working for them, or they're having side effects or contraindication, that you focus them back to their primary care physician. Okay, currently there's 4 FDA-approved medications. We're going to go through these relatively quick. You have all the information in your book and on the CD-ROM, and I'm not going to insult your intelligence in terms of going through all of them quickly and pretend like I'm going to give you all the information that there is about them. What's most important is that you get an understanding as to what those 4 pharmacotherapies are. And any of you that have been around for any length of time know that the one pharmacotherapy medication that we had available to us since 1951 is disulfiram or Antabuse. It's a 250 milligram tablet that is taken once a day, and we know what happens. You take it, you drink, you get sick. So obviously, it's a medication that you want the client to be aware of that they're taking, because it can be crushed, broken down, mixed in with food, and given to a client that way. Has that ever happened? Probably so. We probably had some spouses or significant others that were going to teach somebody a lesson at one time or another, or trying to get their attention in terms of the impact that alcohol is having on them. But if you're going to engage a client in a willing participation at behavior change, you want them to know what it is they're taking. So disulfiram is certainly a medication that there's a lot of side effects to it, and a lot of medical indications that you want an individual to be aware of, because it's not just about taking it and getting sick. If you've got heart problems or you have other types of physical maladies, then it's not a medication that perhaps could be taken. But if you're a right candidate for it and it appears appropriate, it is a medication that can be taken daily. It's an oral medication, and again, it's a 250 milligram tablet that you take once a day. Okay, and so we went all the way from 1951 to 1994 before we got the next medication that became available. It was originally known, it's Naltrexone, but originally marketed as Revia, and it's out now on the secondary source as Depade. It's the thing about Naltrexone, it's a 50 milligram tablet that you take every day. It can be crushed, diluted, mixed with food. It's one that, again, it blocks the pleasurable effects of alcohol. And what we do know about naltrexone, it also works with opioids. We're looking at it as it relates to alcohol. It's an antagonist, so it blocks the pleasurable effects. Well, what we do know about human behavior is you take a medication or you take a drug, you take alcohol, and you don't get the desired outcome effect. Human behavior tells you that you quit doing it. But again, it's a voluntary medication. It's a medication that folks need to know that they're taking and need to be an active participant in it. But it's another medication that can be introduced to a client. And oftentimes what you'll find is that a client may come to you and say, "Hey, Jerry, tell me a little bit about this medication that you take. If you take it, you don't necessarily get sick, but you don't get the desired outcomes and effects from the alcohol." And they may say, "Hey, and I also had a friend that was, that was taking OxyContin, and they were on naltrexone, and when they took it, they didn't get the same kind of effect they used to get." Again, you as a clinician, as a counselor, need to know that that medication works effectively with both of those drugs, and knowing what its implications are, knowing what the side effects are. But again, you're a participant in helping that individual arrive at whether or not that is a medication that they want and perhaps could be involved with. Again, depending on what stage of change they are at. If they're coming into you and they haven't even recognized that they have a problem, no medication intervention or pharmacotherapy is probably indicated at the time. The person has to recognize that there is in fact an issue where the particular alcohol or drug that they're using is causing some kind of interference in their life. So we're at least looking at the contemplation, or hopefully at the preparation stage, before you're going to even help a client begin to look at it. It doesn't mean that you can't talk about it before then, but there's no sense setting them up for failure. If they're not ready to accept change, then introducing them to medication-assisted treatment is probably not the wisest thing at that point. But again, remembering, they can take that information, they can go see their family physician, and they can get prescribed. Then you become an integral part of that interdisciplinary treatment aspect of knowing what medication they're on and how it's affecting them. Okay, so we go another 10 years before the next medication comes on the market, which is a Camperset, marketed as Campril. Okay, it's a little different medication. You take two 333 milligram tablets 3 times a day. Those are pretty good sized horse pills. They're rather large. Folks that have trouble taking large oral medications oftentimes will have a problem with this particular medication. The fact that it has to be taken 3 times a day, there's a lot of experience, there's a lot of work that you can do with clients in terms of journaling or helping them understand taking the medication, getting them ritualized around taking that particular medication. Now, this is a medication, though, that cannot be crushed or broken or diluted because it breaks down the bonding agents in it, and it becomes a lot less effective. There have been some clinical studies that show that it is a medication that if folks are having trouble taking it in that large a dose, that they can take it in smaller doses, and it's still found to be effective. But what's most important, again, is that, this is a glutamate receptor modulator type of medication where it's working across the presynaptic and postsynaptic area and modulates the release of glutamate, which is it produces a desired effect for us and is a reinforcer. So if it's modulating how much travels across the synapse, then what it is actually doing, how much is received on the other side, is being modulated as well. So what it helps with is the post-acute withdrawal issues. And what we know a lot about in early recovery from alcohol dependence is that folks relapse early on because of post-acute withdrawal issues, cravings, thinking about drinking, returning to behaviors. This medication, and they'll be honest with you, if you look through all the clinical trials, the pharmaceutical company that produces it will tell you, oftentimes they don't know why a Camperset works the way it works. It just works. And I don't know that we need to necessarily question that, other than we know that in the clinical trials that this medication done in conjunction with, as with any of the other medications, done in conjunction with some form of psychosocial therapeutic intervention is extremely successful. But again, a Camperset is another medication that, if taken and used appropriately, can be extremely effective in working with the early symptoms and the early issues around recovery.
My first program, I was in a 28-day program, and I knew my drinking career was not done. I knew I was going out, I was getting in my car, and I was going home and having a drink. So I continued drinking. I got myself in more trouble over and over, and I decided I was going to stop drinking on my own with no doctor help. And for 3 days I was in really bad shape. the shaking, the sweating. I couldn't even walk. I went into an alcoholic seizure, and I was unconscious for 5 days. They told my family to prepare that I was not going to make it. I did wake up. My father asked me to wake up, and I woke up on Mother's Day. And I gave the promises, I'm sorry, all the words, I'm never going to do this again. 2 weeks later, I was right back where I left off. I was like it never happened. I was mandated to another rehab, and my insurance covered it for 58 days. I thought I was getting it, but like in the rehab, they told me I was in denial, and I minimized everything, which I know I did. I got out of rehab, thought everything was going to go okay, and I was back to drinking. I'll never forget that day. I was just laying in bed alone. My apartment was a mess, which is not like me. I wasn't dressed. I felt sweaty. I was shaking. And I just had enough. And I was honest with my doctor, and he eventually told me that the Vivitrol would be coming out, and he explained it to me. He asked me if I was interested, and I told him very. He told me we're going to set up an appointment, and he told me that I had to get myself into a program, which I got myself into the 12 steps of AA. And then 3 weeks later, I started the Vivitrol. I get the Vivitrol every month. I just got my last one last month. It was my 12th shot. I celebrated my anniversary July 3rd. Since I've been on the Vivitrol, I've seen my life change tremendously. I eventually graduated from school on February 2nd, started working at a doctor's office February 5th. I have my children back in my life. They're not embarrassed of me. They told me they're proud of me. The Vivitrol, I noticed I'm not as anxious. I'm able to sit and wait for appointments. I'm not worried what I have to do in 10 minutes. If something happens where I didn't plan it, I don't get myself all worked up about it. I, deal with it. Like today, the plane, I had problems getting onto the plane. I read a book. I was fine. I find I'm a lot more patient with people. I find I'm honest. I've gained weight. I was 97, I'm up to 120. I told my attitude on life is very different. I know the Vivitrol doesn't work. It's not a miracle. I know that. I know I have to also go to my meetings. Those are very important to me also. It has to be a combination, in my opinion. That's what's working for me. I get it through my behind. I get a little bump, and it's sore for a few days. But if you rub it, it goes down and eventually goes away. Every once in a while you get a little feeling of it, but it's not enough to make you uncomfortable. I was asked if I had side effects. The only side effect I have had is nothing but joy and pleasure. It's given me so much more to my life. If it's just that little pain and a bump on my behind, it's worth it to me. I'm a satisfied customer. I am so grateful. I love being on my sobriety. I have such a good time with it. I didn't think I was capable to go out dancing without drinking. I went to my first AA dance dinner. We had a ball. I just want to say that there is hope, and if you want it, you can get it. All you have to do is ask.
The last medication that became available for pharmacotherapy intervention is Vivitrol, which is a suspendable, injectable injection of Naltrexone in injectable fashion. It's a 380 milligram shot that's given in the buttocks once a month. The obvious issue around Vivitrol would be when it's in, it's in. There can't be any decision that I don't want to take it tomorrow, or I'll choose not to take it tomorrow. The mechanism of action is the same as Naltrexone, because it is Naltrexone. It's just in a extended release fashion, like a lot of our medications that we see on the psychotropic side. So when it's injected into the buttocks, it's there, it's in for the month. The decision to use can continue to be there. The pleasurable outcome and effect won't be there for at least 30 days. from what I understand, and it's an expensive medication, but from what I understand, it's successful in terms of the folks that are using it, because it gives them a 30-day window to work with in terms of looking at desired outcomes and effect. But again, it's one that for some folks, they have an allergic reaction to the suspension that it's in that's shown sometimes. Some folks have problems at the injection site because it is a large injectable, and it's done into an area that for most of us isn't too much of a problem because there's a lot of little extra flesh there to put it in anyway. But it still is, and they rotate between one side and the other. You're not getting it in the same cheek every month. So, but it is a medication that has been found to be real successful. What's important is that with these medications, one of the questions that comes up is, what's the difference? Which one do you use? Which one's more appropriate for an individual? A lot has to do with, again, working with the individual, helping them understand, and for you gaining an understanding when you're working with them, what is the most effective, what's the most desired outcome at that particular point. If you're looking at antabuse, for someone that has a lot of issues around control, and they want to look at how can they deal with craving and control, a combination of using antabuse and a Camperset oftentimes can be used. A lot of these medications can be used interchangeably, but what you have to look at is what's the desired outcome and effect for the individual. Having them work with their prescriber in terms of what's going to be most effective for the stage of change that they're at. Okay, now we're at the similarities.
I detoxed about a year ago. About 2 months into sobriety, my physician had introduced Camprol. I was going to be one of the first patients to take it, and said that it may help with cravings. We don't have experience with anyone else so far really using it. Would you be interested in taking it? Absolutely, sign me up. And right away, within the first week, I noticed a difference. I don't think I'd still be sober if it weren't for the medication. I really don't. It's just enabled me to do more things. As much as I used to avoid activities that didn't have alcohol when I was drinking, I was worried I was going to have to avoid all activities that may have alcohol, and that has not been the case. I wouldn't recommend it in early sobriety. By taking the Camprol, I think it made it easier to be in counseling and therapy. The medication makes me more available to hear about other coping strategies. It makes me less irritable. It makes me less sarcastic and cynical about the suggestions that are presented to me. You can finally not only not be cynical about some of the suggestions that are made, but actually be able to employ them, which is a huge change, because I think we got in the mindset, especially people who've tried to quit on their own, of I've tried that, I've tried that, I've tried that, I've tried that. It doesn't work, nothing works. I'm so unique that nothing on the planet works. But it does. But maybe your brain wasn't available to suck it in at that time. I truly believe it is a medical disease. I treated it just as I would if someone had said I had cancer. I can't take care of this on my own. I've tried. And I needed to see a medical doctor, and I needed someone who specialized in addiction. So that's how I found my doctor, Dr. Poss, and was able to detox there. We do a lot of intensive outpatient therapy, a lot of 12-step. I hated AA. Now I realize it's instrumental in the process of getting sober. It's nice to have all other tools and things that can help with that, but 12-step work is really invaluable and a key component. It's very complementary to everything else that you're doing, including medication. I drive a Volvo, okay? It's a safe car. You can think of sobriety as safety. Just because it has airbags all over it and it's made of steel and it'll crumple down if it gets hit in an accident and has everything but fire extinguishers in it, just because it has all those other safety features, it doesn't mean I drive around without my seatbelt on. It needs to be both. Belts and suspenders, it just works better that way. like a condom. You know, you can possess the condom and you can buy the condoms, but if you only put it on after you have sex, there's really no benefit to it. So it's not something magical where you drink too much, take all the Camprol. It's more of that you want it to be level in your system so that you feel good all the time. You don't want highs and lows. I just think it could make a big difference, especially for people if you've tried before and there just wasn't enough to get over that hump of early sobriety or to maintain it. I think it's very important to try this. We're very lucky that it's available, and I think it's really going to make a huge change to the people that are successful.
They're all FDA approved between 18 and 65. Does that mean that folks who are under 18 aren't on it and people that are over 65 aren't on it? Absolutely. That's a prescriber determination. It's off-label, but they make that determination. With polysubstance abusers, is it used? Very possibly. There's just not a lot of research that's been done around polysubstance abusers. They're all Category C. For those of you familiar with what it means to be Category C, that means if the risk of continued use is greater, the prescriber makes the determination as to whether or not it's used when a female is pregnant. I said this earlier, I'll say it again. All of the research with them, all the clinical trials with them shows that these medications are most effective when used in conjunction with some form of psychosocial therapeutic intervention model. And obviously what we know beyond that too is the involvement of anonymous fellowships in addition to that. Not using anonymous fellowships as a replacement for therapy, but used in cohort with it.
We'd like to just begin to review some of the strategies for motivational interviewing and to kind of ask, why are we talking about pharmacotherapies and motivational interviewing? For a couple reasons. One is we're just at the beginning of learning about how medications can affect addiction and how medications can affect the brain and other parts of our metabolism, and so that it's important for us as clinicians to understand what the medications are and to, when it's appropriate, educate our clients about them and also find a prescriber that we can work in conjunction with, because that's when the consumer is best served, is when we're working in conjunction with a prescriber. And that hopefully in 5 or 10 years, instead of having 4 medications, maybe we'll have 8 or 10 like we have for hypertension, diabetes, asthma, and other chronic illnesses. So we talk about open-ended questions. We know that when we're doing motivational interviewing, we're trying to get the client to understand, why is it in my best interest to change? So when we ask open-ended questions, it makes them think about the response. If I said to someone, did you use alcohol last night? And they say yes or no, then I have to ask another question and the conversation doesn't really go very far. But if I say to them, what did you do last night? Tell me what you did after you left work. That's a much different conversation, and chances are I'm going to get a lot more information from it. So we try to avoid closed-ended conversations in motivational interviewing. And you all know what closed and open-ended questions are. I think the other thing that's really important is that when we look at open-ended questions, we're better able to really figure out what the person's perception is of what's going on. If I said to someone, do you have a problem with alcohol? And they're pre-contemplative, what are they going to say? No. If I say to them, gee, do you tell me about, what happened that got you involved with the court system that brought you here for your first appointment with me, that's a much different conversation. Asking someone who's pre-contemplative about, is there anyone in your family that's concerned about your alcohol use? I know that you're not, or your marijuana use or your heroin use. You don't seem to think it's a problem right now, but is there anybody in your family that thinks there's a problem? How are things going at work? Have you ever missed any work? Have you ever gone in late because you were out partying the night before? That's a much different conversation. When we look at, this chart is all in the handout that you're going to be getting. I I think the most important thing with motivational interviewing and using the stages of change model is that to understand that when we're talking with people who are pre-contemplative, we don't want to use words like problem, addiction, abuse, because from their perspective, they're just drinking like all their buddies or everybody else that they work with. They don't see it as a problem. So the minute we use that kind of language, they become defensive. And when they become defensive, they shut down. So it's really hard to help someone develop any ambivalence if they're in this tug of war with us around, well, I don't have a problem. So we use words like concerned. We use words like, tell me, what's your drinking like today versus what it was 5 or 6 years ago. Being able to do a timeline feedback, looking at when did you have your first drink? Let's talk about your drinking over the last 20 years, and then let's do another timeline and look at your educational experience, your vocational experience, your legal experience, and is there any connection between when your drinking increased and when you started getting involved in the criminal justice system? So we're looking at ways to raise consciousness and to really look at beginning to create ambivalence.
Tell me about that relationship.
Well, we have a good time together. She's what I consider a good influence on me, so I really want to hold on to her. Yeah,
What does she say about your drinking?
Well, she says I do it a little bit too much. When I first started out with her, I didn't do hardly any drinking at all, and it was fine. It was fine. But then I guess the real me started to come through, and I started to just enjoy myself a little bit more with alcohol, and because it's fun, it's nice, it gives you a little buzz, and feels good. But she doesn't drink, so she really thinks I get a little bit out of hand when I do drink.
Okay. When you do drink, so there are times you're with Wendy when you don't drink.
Sure.
Okay.
Oh, yeah, sure.
Can you tell me a little bit about that?
Well, we have a good time together.
Reflective listening is a great skill for teenagers. If you have any teenagers at home, it really kind of mitigates a lot of acrimonious discussions. But typically, if you're doing motivation interviewing well, the client is talking for a good 40-45 minutes of the 1 hour session, and the counselor is directing it, and they're asking questions. They may be doing some summarizing, but the vast majority of the work is done by the client. So if you're doing motivational interviewing and the client's only talking for 5 or 10 minutes, then you need to kind of re-look at the different strategies that you're using. Once again, we're looking to increase internal motivation to change and helping people make a decision to change. With reflective listening, it's a way to really kind of get on the same page with the individual. Being able to reframe something like, I'm only here because my parole officer sent me. Being able to say, to reflect back to them, you're really uncomfortable being here because you really don't think you have a problem. That's a much different discussion. We really want to help people understand what they're saying. Reflecting back to them in their own words makes them understand that you're listening to them, that you care about them, and you're being able to understand their life from their own perspective. It helps to clarify people's thoughts. It's also reassuring to the person that you're actually sitting in the room listening, and you're not kind of thinking about your grocery list or whether you're going to get home in time to watch the game or do the grocery shopping. So I think that utilizing reflective statements, it's a very simple strategy. It's something that I work with people that have major mental illness and co-occurring substance use disorders, and we use, when people are psychotic, when people are really manic, reflecting back to them what they say is a way to help diffuse the energy that sometimes people get when they're symptomatic. The roadblocks, and this is a fun thing to do in supervision, but we want to ask clarifying questions, and we want to be clear that we don't make assumptions. I used to do evaluations at one of our state prisons in New Hampshire, and I used to just always assume that people were going to stay sober when they got out of jail because, that they had decided that, they had this revelation that, wow, this is not in my best interest. And when I learned about stages of change, I asked the guys, how many of you are going to stay sober when you get out of jail? And everybody raised their hand. And then I said, how many are going to stay sober after you get off probation? And 2/3 of the hands came down. Because their motivation to stay sober was not because they had internalized that they needed to change, but because they didn't want to go back to jail. So sometimes the questions we ask, we get better information. One of the things in motivational interviewing that we really don't want to engage in, and I don't think most of us want to engage in these things anyway, are commanding people. You know, saying like, you need to go to 90 meetings in 90 days, end of questions. That's not a motivational interviewing strategy. Threatening people. If you don't do 90 meetings in 90 days, I'm going to have to tell your probation officer. That's threatening. Giving premature advice. I really think it's important for you to go to 90 meetings in 90 days when the person isn't even acknowledging they have an alcohol problem. Moralizing, criticizing, eliciting shame in folks. Some of the things there are different suggestions for using reflective listening. It's a handout in your booklet that I had taken when I was doing more direct counseling. I made a copy of that sheet and stuck it in my desk drawer. In between clients, I take it out and look at it just to help refresh my memory. For example, the client says, I don't think I have a drinking problem. I just drink 4 or 5 times per week with my friends. And the counselor could reflect back and say, you drink more days than not during a week, and you do not feel you have a drinking problem. And once again, you want to use your tone of voice, so it's not like you do not feel you have a drinking problem, you know, so it's important. Another way to utilize reflective listening, the client could say, I got way too drunk last night and really feel it this morning. And then just reflecting back, so getting drunk last night did not feel good. Once again, we're trying to elicit motivation, we're trying to raise consciousness, and we're trying to help people make a decision to change. And the next strategy we're going to talk about is affirming.
Well, I'm proud of you too. I want you to know that,
Thank
Carmen.
you.
I'm very proud of you. It's a big deal that you came in, particularly when your husband was not supportive and
Yeah.
you really felt like this was the next step for you. I'm very proud of you, and you're doing wonderful.
Thank you.
And I will give you the tapes and the literature and my card. And
Oh, that would be wonderful. I look forward to give it to him.
yes,
And I can read those books if it's in English, and he can listen to the tape and maybe make some sense to him.
yes.
That is very important for me to be here.
I think one of the most important parts of looking at motivational interviewing using that technique is one of the things that Mary said, and that's allowing the client to internalize what's going on inside and to bring it forward rather than during a session we're spending 45 out of the 50 minutes telling them what they should be thinking or should be feeling or what they should be doing or should not be doing, rather than trying to create that ambivalence within them through the techniques and the skills and strategies that we use, and elicit and solicit that behavior from them rather than us putting it down onto them. The ownership changes an awful lot. Affirming, when we're looking at primary roles, as clinicians, that's probably one of the things we should be best at, and that's noting the strengths and also noting the weaknesses, but reaffirming to the client what's going on with them, the changes that they made, the things that have happened that are good, and pointing those out to them. It's statements of appreciation. You can focus on the client's strengths. Things like, I've noticed that you're really good at identifying which areas of your life need improvement. How do we find that out? Well, the easiest way is asking them, and then when you hear it, to reaffirm it back to them. Encourage them in spite of what's happened in the past. How many clients have ever come in and darkened your doorstep that they got it the first time around? Maybe one over the course of your entire professional career, but for the most part, they come in, they try, they fail. It's part of the disease. It's part of what goes on. But as a clinician, again, reaffirming that with them, helping them understand that's part of the normal process, and not using a tone of voice of, oh, come on, you know better. You've done that before. You've failed at that 5 times before. What's it going to take, 6? Again, it's how you present it to them. and making encouraging statements to them and elicit positive responses. Like you're making great progress. Tell them how you feel in comparison to how you felt 2 weeks ago. What happens oftentimes is, clients come into us and we're dealing with, problem du jour, what's going on today, rather than focusing on that transition of maybe where they were last week, whether it's a homework assignment that you gave them or something that they've agreed to do. But what they do is they come in armed to distract and go off in a different direction. Not that you don't allow them to do that for a period of time, but looking with them and trying to point out to them where they were, where they've made progress, and how they feel now, perhaps in comparison to how they felt just a couple weeks ago. Acknowledging the positives, point out and celebrate steps that they've taken so far. I think a lot of times what happens is that we get stuck along with the clients in what they're not doing versus what they have accomplished. Again, they may move 5 steps forwards, fall 3 steps back, move 2 forward, fall 1 back, move 3 up, fall 1 back. What's important is that they keep moving forward and remind them of their past successes, compliment them on their attendance at sessions. They got to be in front of you to do that, of course, but, oftentimes they'll not show up because of a lot of different reasons. One could be in the session before you were working on some critical issues with them that perhaps were painful and that they didn't want to move forward with. Celebrate who the client is as a person. Okay? The next strategy we're going to look at is summarizing. Summarizing, we do it all the time in clinical sessions when we're working with clients, and oftentimes we don't stop and look at what that is, but it does give us a way of pointing out discrepancies. It allows you, in working with the client, to collect their scattered thoughts. Oftentimes clients are all over the place. They'll come in and they're talking about this, they're talking about that, they're talking about something that perhaps happened 2 sessions ago, something that may happen next week, something that's happening later today. But what it is, it's taking those series of statements by the client and presenting them back to them in some type of condensed version. It's being able to look at that and to synthesize that information so that it doesn't appear as scattered. Because if it feels scattered for you, can you imagine how it feels for them at times? And generally what you're doing is you're drawing that information that you want to be good at, drawing that information from them and condensing their words, not necessarily what you perceived as what was being said, but actually using their words, reminding them of things that they may have said. It allows one type of, and we're going to look at the 3 different types, but the one type allows a transition. There's 3 types. There's collecting, linking, and transitional. Collecting summaries are used, obviously, to do that, to gather several different statements or thoughts about change presented by the client and then combined into one cohesive thought. And generally what you want to do with that is you want to keep it condensed. But what you want to do is you want to be able to collect that information. Maybe look at something that they said a couple weeks ago, or something that they said maybe last session, or that they said earlier in the session, and you're bringing it back, you're collecting it, you're bringing it down into one condensed statement for them. But what you don't want to do with that, by the way, is you don't want to interrupt the flow of a session by distracting and pulling off into a different direction because you thought at this point this would be a good time to summarize. Linking summaries are another way of compiling the thoughts and feelings of a client. They look at previous sessions, they look at earlier sessions. They're used to encourage the client to reflect on 2 or more comments that he or she may not have seen or is related or interconnected. Oftentimes they may say, and I'm sure you've run into this, they've said something 2 or 3 sessions ago, and then they go back and they make a statement that perhaps contradicts it. And what you can do is link back to, rather than saying, whoa, that's not what you said. 2 sessions ago you said you were only drinking with family members. Now you're telling me on the way home you're stopping at a bar and you're drinking with old friends. Pointing out the discrepancy through linking back information that they had said before and bringing it forward to something that they're saying now allows them the opportunity, without feeling shame, to look at the discrepancy of information that they've presented to you. It also gives them a chance to raise the ambivalence over what they perceive as what information they're providing you with at different points in time. Transitional summaries are just that. It allows you to shift from one topic to another. How often a client comes into us, and again, as we said, we want the client doing the majority of the talking during any clinical session. But oftentimes what you'll see with them is they're moving on, and they're doing a lot of talking, and they're jumping around a lot, and perhaps are not working in a condensed area and not focusing on what the treatment plan is at that particular moment, or the strategy that you had agreed to work on during that particular session. So a transitional summary will allow you to stop at that point and be able to say to them, this is what I hear you saying up to this point, and then through using a skill and a strategy move on to, however, can we go a little further and look at this? It allows you to, in a sense, take control, but at the same time being respectful of where the individual is, to move them forward to another topic and to look at other related themes. Speaking of related themes, that allows you to work with them and to help them to move forward through that type of summarization.
So on one hand, you're working every day. You're going to work every day. From your perception, you're doing a good job at work.
Right.
Okay.
So I think.
Yeah.
You know.
And you're bringing home the paycheck every week.
Right.
Okay? So you really feel like alcohol isn't interfering with your life.
Right.
And on the other hand, your wife is concerned because sometimes you stop off after work and you don't come home. Sometimes when you've been drinking, you're not very nice verbally to her.
Right.
And in the morning, sometimes you're hungover and maybe a little irritable.
Right.
So I guess there's a couple different perceptions of what's going on with your drinking.
Right.
Yeah. And work is concerned as well.
Absolutely.
Yeah.
Of course, I think, you work hard, you play hard, and
Right.
that's the
Yeah,
theory
yeah,
I go by,
yeah,
so.
yeah. And I'm sure most of the guys you hang out with have that same
Yeah,
theory as
yeah,
well. Yeah.
yeah.
Just to kind of give an example of being able to elicit change talk, we're currently working with a young man who has recently been diagnosed with a thought disorder and doesn't really see much motivation to stop smoking pot and drinking with his friends. And we started working with him maybe 4 months ago, and he was using pretty heavily, and as a result of working with him, he started on a contingency management plan. And he came in, I don't know, maybe 2 weekends ago on a Monday, and he said, this is just too hard work trying to score drugs, And those are the kind of statements we're looking for when we're thinking about eliciting change talk. He's putting more effort now into getting his drugs and to drinking. He's feeling bad in the morning when he wakes up, and his resources have certainly shrunk as a result of the contingency management. So, being able to use a number of strategies in addition to motivational interviewing is also very effective. So when we're talking about looking at change talk, we really have to listen to those statements like, this is hard work. It's hard work going out at night, or I'm really sick and tired of being sick and tired, which is the classic change talk that we often hear. And those are the kinds of things we need to look on and build on, the statements we need to look at and build on. So they're also called self-motivational statements, where somebody's really making the statement why they have to change. And that's the beautiful thing about motivational interviewing, because when we're doing it well, the client is telling us why they need to change, and they're making the case for why they need to change. The disadvantages of the status quo, what's it like to have to, leave here on a Friday, spend the weekend, having people come out, reach you for your meds, you're not there, your parents are talking to you, and then you come in on Monday and, you're hungover and your television's missing, or you don't have any money to pay your groceries for the rest of the week. Is this still feeling like a fun way to live? those are the kinds of things we're going to look for. Advantages of change. Well, what would be the good things of deciding not to drink? You know, what are the not so good things about drinking? What are the good things about drinking? And being able to have that discussion with them so that they can begin to say, well, you know, I can socialize better. It's fun. Those are the good things. The not so good things are, I get really depressed in the morning. I miss work. My boss is starting to get suspicious. My family's on my back. So they begin to really look at the good things and not so good things of using. Optimism for change. Sometimes we have to hold the hope for people, and when we were talking a little bit more about affirming, it's about holding hope for people, being able to say, you know, you do have strengths. There are things that you can do. You have been successful in the past. And being able to have that optimism for people is sometimes the difference between people being able to change and people staying stuck in their addiction. People's intention to change. And it's important to understand that somebody may make a decision to change. I may make a decision to lose 20 pounds, and it may be really important to me on a scale of 1 to 10, but my confidence level may be about a 4 because I'm traveling for the next month. And when we talk to our clients about change, it's important for us to understand how important is it for them or how confident it is. I've known people who say, you know, I can stop drinking anytime I want. I just don't want to. It's not important to me to do it right now. So the confidence that they could do it if they wanted to. All right, we're just going to go through this. So being able to ask evocative questions, the disadvantages of the status quo, the advantages of change, optimism. These are all questions that are available in your handout. And then using the importance and confidence ruler is really eye-opening for folks. Asking about extremes. You know, what scares you the most about continuing to drink? You know, if your life could be the best it could be, what would that be like for you? The magical wish question is a good question to ask. Being able to look backwards. Do you remember when you could drink and you didn't have a problem? Do you remember what life was like before you started smoking pot? Those are important questions to try to connect people back to what their life was like and what their thoughts were like before they started to suffer from either an abuse or dependence. Being able to say, what does your family think about your drinking or your drug use? What's your probation officer saying if you use again? What's your commanding officer saying if you use again?
Is it that you really want to stay with this company?
Look, this is good pay.
Okay.
Okay, you know, my boss said if I do this program or whatever, you know, and do what I'm supposed to do, you know, the possibility I might advance or, something like that.
So he really likes you, obviously.
Yeah, I guess so.
Asking permission and giving advice. I think that this is something that's extremely different in motivational interviewing, and it's an important concept to get, because in motivational interviewing we never give advice without asking permission first. You may be sitting there thinking, I know the answer to this. I know the best thing that's going to really help this person turn around. But we don't do that unless we give advice first. Because remember, this is a collaboration. I'm not the expert who's dealing out the therapy. It's a collaborative event. So being able to say, I understand from what you're saying is that you would really like to stop smoking pot, but you're really not quite sure how to do it. If you're interested, I know 3 or 4 different things that might be helpful for you. And if they say yes, you continue, and if you say no, you don't. Being able to say to someone, you sound really discouraged, and you sound like you're really frustrated, and you're feeling very hopeless. I've worked with other folks that have felt that way. Do you want to know what some of their solutions were? And being, once again, able to understand that if they say no, that's their autonomy. Okay, there are only 3 times when, in motivational interviewing, a clinician would give advice. The first is when the client specifically asks for the counselor's expertise. The second is when the client has granted the counselor permission to dispense the advice. And the other time is when a client is obviously headed in a direction that is detrimental to his or her recovery.
The next skill area is looking at presenting menus of options. And you might say, well, you've gotten all the way down to here, now you're going to talk about what are the options for treatment. Because at some point, you know, in working with the client, and again, key word there is working with the client, you begin exploring with them what are the options that they have for treatment. And what's most important there is that you, as a counselor and clinician, know what all of those options are in your area and what is most effective for the individual. Someone that comes into you that isn't even sure that they have a problem with alcohol or opiates, it's probably not a good option of treatment for them at that point to suggest that they go into some type of extended care or to put them into an IOP. But if you look across the country, most of the intervention strategy programs that we have available for clients are programs that are not set up for clients that are in the contemplative and pre-contemplative. And the majority of folks that come into and darken our doorstep, that's where they're at when they come in. But the options for treatment that we have available and most available for them are contraindicated at that point. And what's really important is looking at it with the client, looking at what all of the options are. Oftentimes that we get stuck in cookie cutter types of treatment formats for our clients. Because it worked for these 3 clients, well, then it's got to work for this 4th client. So what's most important is that we're aware of what all of those possible options are, what the resources are, not just in our local area, because sometimes you have to look outside of the current area that you're in, depending on what the client's needs are. If you've got a client that's in need of some type of specialized treatment program and it's not available and it's something that they could benefit from, you as a counselor, it's real important that you're aware of what those are. It's establishing not just a client worksheet. Treatment plan in its purest form is looking at what you as a clinician are going to do and what the client's going to do. But oftentimes what you want to do is you want to do a change work plan sheet with the client. And this is in the back of the information that you have. It outlines real clearly for them what their roles and what their responsibilities are. Everything from showing up for appointments to making commitments to journaling, making commitments to meetings, making commitments to read particular articles. It's looking at all the things that they're going to be involved with in this transition of change. The next part of that would be looking at with them how they are going to accomplish that. And the more that can originate from the client, the better. You know, if you're there saying, this is what you need to do, this is how you should do it, that's your perception. And it may not necessarily be what they want. It's encouraging them and helping them understand, because sometimes they're going to be at a loss at what to do. Oftentimes they're going to be working off of what's worked for them or perhaps what hasn't worked for them in the past. You know, if they continue to do the same thing with the same negative outcomes, then perhaps it is time to look at doing something different. And we're not going to go through the examples because we're running shorter on time. Being knowledgeable of resources is what's really important. And what's being even more important is looking at with the client what can be most effective for them and not what you find most comfortable in the skill and strategy and intervention that works best for you.
So for today, what would you like to do? What would you like to do for your treatment?
Well, I guess I could start looking at maybe how much I'm actually consuming and maybe cutting back or working more with you. And
Well, you have some options here at the clinic. Would you like to hear what they are?
Sure.
Okay. We could continue to meet every week. We also have an intensive outpatient clinic that you could come to. There's also a residential program here connected with the clinic. And we also have a group of alumni who meet and every week for support. So there's a variety of things that you could do to learn more about the benefits of not drinking. One of the best conceptualizations of both stages of change in motivational interviewing is the whole concept of resistance. As I mentioned earlier, we're looking at resistance from what we're doing as clinicians. So if I'm in a session with someone and I start to feel that wall and they're not listening to me, then I need to take a step back and look at, am I using action-oriented language for somebody who really doesn't think they have a problem? Am I offering an action-oriented intervention for somebody who's still really ambivalent about them having an alcohol or drug use disorder? So that when we look at rolling with resistance, it really comes from when we're trying to impose our plan onto the individual and we're not hearing what they're saying or what they're going to work. And what I always tell my staff is that there's plan A, which is usually what the participant or the client wants, but there always has to be a plan B. So if your plan isn't working, then let's come up with a plan B. Let's negotiate for a higher level of care, higher level of accountability. And then the universe has always been really good about providing opportunities that get plan B into action sooner than probably the client would like. But there are 4 types of resistant behaviors which we've all have encountered. Arguing with the person, the client is arguing with us, no, I don't have a problem, no, I don't need to go to meetings, it's not me, it's my job, it's the people I work with, it's my family, it's nothing about what I'm doing, it's the external world. Challenging. Well, that may be true for the 500 people you worked with, but it's not true for me, because I'm really unique and I'm different. And being able to challenge us in whatever it is that they're presenting with. I worked with a man who was court-ordered into outpatient treatment, and he came in with a Budweiser hat, a Budweiser racing jacket, a Budweiser belt buckle, and a Budweiser t-shirt, and he walked into my office, sat down and folded his arms and glared at me and said, well, what are you going to do? And it was pretty clear to me I wasn't going to convince him that day that he was going to stop drinking. And so I just talked to him about, well, tell me about Budweiser. What's, you seem really invested in it. And we spent, like the first couple sessions just talking about his love of Budweiser. And he was French Canadian, and he came from a family that all the men drank, and strong men drank, and weak men couldn't drink. And after a while he stopped wearing the hat and belt buckle. He always wore the belt buckle, but we got rid of the rest of the Budweiser stuff. So, discounting, questioning the person's authority or expertise. Well, how do you know? You haven't lived in my shoes. You haven't experienced what I've experienced. You've never been to jail. You've never had your license taken away. How can you possibly know what I'm going through? Also, hostility. When our clients start to get hostile with us, we really need to take a step back and look at what we're doing. Sometimes we just have to agree to disagree. Interrupting, the client is interrupting. Well, if the client's interrupting, then chances are we're talking too much from a motivational interviewing perspective, so that's a really good sign that maybe it's a time to take a step back and start doing some listening. The other thing is when they start to talk over us, that means they're really starting to defend their position. So if they're really feeling defensive, then we need to take a step back and say, okay, I'm in action, and this person is still in pre-contemplation or contemplation. So I need to get back to where they are. Cutting off, once again, we've elicited defensiveness. The person's trying to defend their right to drink. And what we're trying to do in motivational interviewing is get them to understand and defend their right for treatment, so that it's the exact opposite of what we're wanting to do. Negating, no matter how bad it is, it's not as bad as you think it is.
So it's pretty clear you're not really committed to doing much about your drinking, but you might be interested in thinking a little more about why these friends are so concerned?
Yeah, I guess I owe it to them, but I don't really think I have a problem, and I got this under control. I don't get it.
Right.
So I'm like...
Well, I wonder if you could do kind of an experiment. I mean, like over a week or so, try and figure out the next week maybe, figure out how whether you could control it a little bit more, whether you could stop at a certain point. Is that something that you might be interested in doing?
I mean, I can do that because this is not a problem. So yeah, I could do that. It'd be no problem. That's easy.